Hello and welcome to the 2015 CROI here in Seattle, Washington. My name is Christopher Brennan. I'm here representing IFARA TV. I have with me today Kian Bichoupan from the ICAHN School of Medicine at Mount Sinai Medical Center. Kian is here today talking about cost analysis with hepatitis C therapies, and he's going to give us some of the breakdown of the different kinds of combinations that do get used for hepatitis C and what the outcomes are from those from a cost point of view. Kian, thank you.
Thank you.
So can you tell us a little bit about yourself, how you got to the CROI, and what it is that you're really presenting, what your study is all about?
Sure. Thank you again for having me. Currently, I'm a PhD student at ICAHN School of Medicine at Mount Sinai Medical Center. I am a PhD student in clinical research. And really the focus of my PhD work focuses on hepatitis C outcomes, real outcomes that happen in the real world outside of clinical trials. So a big kind of theme in my research is really looking at what happens in the real world and comparing that to what happens in clinical trials, because often there's a gap between the two. And that can be because there's differences in the population, there's differences in just the way the study is done, and that makes a very large need for doing studies that address problems in the real world. Mm-hmm. And one of these problems that we chose to address was the lack of response and the need to understand the actual SVR rates or sustained virologic response rates that happen in the real world with hepatitis C medications. So it's a very exciting time for hepatitis C because in the past 5 years, there's been a tremendous evolution of new therapies that have come out. If you look 3 years ago, telaprevir and boceprevir were the standard of care for hepatitis C patients with a genotype 1 virus. And those drugs tended to have poorer SVR rates, around 44% in the real world. And they were, it was very common for patients taking those drugs to have terrible side effects, leading them to stop therapy early. So we did a cost analysis on those therapies in the real world, and found that to achieve an SVR, the cost per SVR with those therapies, with telaprevir-based triple therapy, was $189,000. And this raised a lot of attention, and it also gave a new perspective onto how to look into what we're actually paying to achieve a cure.
Mm-hmm. And can you say over what lifespan is that 189,000?
So that 189,000 is for treatment that could be as short as 24 weeks up to 48 weeks. That's telaprevir with pegylated interferon and ribavirin together. So in 2013, subpopulations and sofosbuvir were approved by the FDA for their individual use, and several physicians actually take subpopulations and sofosbuvir and combine them. Let me take a step back and say that subpopulations is a NS3/4A protease inhibitor for Hep C, and sofosbuvir is an NS5B inhibitor, polymerase inhibitor. So what's been done is that they take that subpopulations, that protease inhibitor, and combine it with that NS5B inhibitor. They combine it, and those are two drugs that are taken once a day. And that patient can take that drug with or without ribavirin and hope to achieve an SVR. And so the Cosmos trial, which is one trial that was a phase 2A open label randomized trial that looked at the combination of subpopulations and sofosbuvir with or without ribavirin, and found that SVR rates were 92%. So the goal of our study that we presented here at CROI was to investigate how that combination worked in the real world. So we did that study, we looked at the SVR rates in the real world, and then we also looked at what the cost was. Because we already did the study with telaprevir, so we wanted to see, well, what's the cost per SVR with these new regimens?
With a comparison.
Yeah, what was the comparison? So we found the SVR rate in the real world to be 88%. And the cost per SVR was actually 171. So even though these drugs were more expensive, because their SVR rate was higher, the cost per SVR was actually lower than it was before. So we went from 189 to approximately 171,000.
Mm-hmm. Interesting. And are these the drugs, I'm sorry for not being sophisticated enough to know right now, but are these the drugs that have made all the difference in the side effects for HCV treatment?
Well, in general, compared to what we had before with telaprevir and boceprevir, the adverse event profile is significantly better with these drugs. I think it's a world of difference. And I think that really shows in the improvement in the SVR rates And it also shows up when you look at the differences in the SVR rates between the clinical trials and what we're seeing now. To kind of give you some perspective, tolapivir and boceprevir, the previous regimens, in clinical trials they achieved SVR rates of 64 to 75%, but in clinical trials we observed 44. And a lot of that was because patients were discontinuing treatment early. A lot of it was because the patients were sicker. But you could attribute that to, a lot of that you could attribute to the adverse events. But here we're only seeing a difference of a few percentage points. You know, we're going from 92 to 88%. And a big part of it is because patients aren't discontinuing therapy. It's once daily, so the adherence might be a little bit better.
Yeah.
Yeah.
Interesting. And when you do the, can you tell us a little bit about how you come to your figures? So how do
Sure.
you,
Sure. So, and this is the same methodology we used for the previous study. So basically, we look at the length of time that the patient was on treatment. We also look at visit costs. So there's really 4 components of cost. Let's go like that. So there's lab costs, there's adverse event costs, there are physician fee costs, and there are pharmaceutical costs. So, you know, every patient will have a baseline visit, every patient will have on-treatment visits, and then every patient will have follow-up visits. And in those visits, there are lab tests that are done, such as viral load, complete blood count, liver transplant monitors, and then finally, there's adverse event management. So, you know, some patients in our study needed to take EPO as a result of anemia, erythropoietin. Some patients were hospitalized, and some patients had emergency room visits. And so those are costs that we include because they could be related to the treatment.
Right.
So at the end of the day, we look at so we had 173 patients that we could sum costs for in our study. So we summed the costs of all those patients and divided it by the total number of patients who achieved SVR. So just to make it simple, let's say you and I are being treated, we both cost $100, but only one of us gets an SVR. The cost per SVR would be $200.
Right, that makes sense. And so, can you describe for the audience what the outcome is of the study, and where this leads us? You know, what kind of recommendations your results are implying we should maybe think about making in the regulatory environment?
Let's take a step back. You know, the 171,000 that we report in the abstract today, in the presentation today, that was based on list drug costs that were present to us from a public database, the Red Book WAC. Payers who are actually paying these costs may actually, these are the costs that we see, but they may have agreements where they don't have to pay that cost. So to address that fact, we did a sensitivity analysis, meaning that what would be the cost per SVR if we discounted the drug costs that were incurred. So if you discount the drug cost by 50%, which could be possible, the cost per SVR goes down to $86,000. I think that's just a very important point to make because some people may think that it's a strict 171,000 per SVR, but it's not. Payers have different agreements with how much they're actually spending on these drugs.
Absolutely.
But back to your point about what this number actually means, I think that's a very important thing to drill down into. So there's several points to take from this. One, with previous treatments, we had cost per SVRs of $189,000. And now with more effective regimens, they're still expensive, but we're getting more bang for a buck in a way. We're getting a cost per SVR that's lower than what we had before. That's one. Secondly, I think this may have implications for how other pharmaceutical companies coming out with new regimens may price their drugs. That's going to be something important. If they see that the cost per SVR with one combination is $171,000, and they may have a more inferior drug, slightly inferior, they may alter the price to make it the same cost per SVR, and maybe you could treat more people that way.
Right.
So
to make the marketplace more competitive.
I should also say that Simsov, so simepivir and sulfoxaflor combination, is available to a lot of places, and a lot of the newer medications that are coming out aren't available yet everywhere. So in many places, this combination is the best potential option for patients. So this type of information is important. I should also say that, in our study, we didn't just look at cost per SVR, we also looked at what types of factors were beneficial or what types of factors were predictive of a patient achieving SVR. And we found some factors that were similar to other studies, such as patients who were prior protease inhibitors, so patients who failed tolacapir receptor in the past were less likely to achieve an SVR now. And that's another factor that's important.
Right. And did you find any, I don't know if you stratified your results after when you analyzed them, but were you looking at HIV co-infected individuals or any kind of subpopulations that was different in?
Sure. So we plan in the paper to actually examine all subgroups that were in the study. In the presentation shown today, we did 3 subgroup analyses. We looked at patients with low and high FIB-4 scores, which is a non-invasive way of assessing someone's liver stage. We also looked at co-infection and mono-infection. Co-infected patients were included in the study. And finally, we looked at patients who failed tolacapir receptor in the past. So interestingly, patients who were co-infected actually had lower cost per SVRs than patients who are mono-infected. I can't make a comment about whether that's statistically significant, but patients with co-infection actually had fairly high SVR rates, and they were higher than mono-infected. I can't make a comment if they were statistically higher because it's a small sample size at this point.
Right.
But in general, we found that co-infected patients do very well on these therapies. It may be because they're well-selected patients. It may be because they're better adhering to their medications than mono-infected naive patients. But yeah,
that's the finding.
That's it. Yeah,
well, that's encouraging at least. So it seems like we have a new regimen here that has less side effects, is a little bit cheaper per SVR, and has a higher SVR.
Now you should know that there's new combinations out, and we're going to be doing studies on those.
Okay.
Soft lidosphere is one, and the AbbVie combination, the 3D combination is another, and those offer some potential great opportunities for co-infected patients. I think that's important to say. Simepivir and sofosbuvir each received individual FDA approval at the end of 2013, and they were used off-label for about a year. And just last November, they received FDA approval for their combination.
Okay.
So the study that we did looked at patients who were receiving off-label combinations. So I think that's important just to mention.
And one thing we didn't mention is the geographic location of your study?
It was all New York.
Oh,
it was
New York specific.
all New York and all patients who were at Mount Sinai. So we did something kind of cool here. We first of all, we got a list of patients who were treated from Mount Sinai providers coming from their clinic. And at the same time, we have this thing at Mount Sinai called the Mount Sinai Data Warehouse, which is a large electronic medical database, medical record database. And basically, we ran a query to find all patients who have an ICD-9 code for Hep C, and we also looked for anyone that made an order, a medication order for simepivir, sofosbuvir, or ribavirin. And we took all the results and did a medical record review on every single result that came back. And that ensured us that we had a consecutive series of patients that started therapy from between December 2013 and June 2014. So that gave us 202 patients to study from.
Right.
So the cohort we're looking at is the entire cohort of patients at Mount Sinai without missing anyone in between.
Right. That's a great use of an electronic medical record. I bet Mount Sinai is probably quite unique for having a functioning electronic medical record system like that.
I think it's becoming more common. I know the data warehouse is a tool that's commonly used. I can't make a comment about other institutions and their data warehouse or medical record, but I can tell you from my experience the Mount Sinai data warehouse is a powerful tool and it's being used a lot for clinical trials and observational studies.
So to get slightly abroad from this topic, while you were here at the CROI, obviously there's a lot of interesting stuff going on. Is there anything that you found particularly interesting, maybe in one of the sessions or in a poster or?
Yeah, let me think. There was one study that particularly caught my interest, and that looked at it was a cost analysis of HIV-infected patients. And I believe the man's name was Shackerman was the first author, and they're from a group from Cornell. Mm-hmm. And basically what they looked at was the lifetime medical costs of an HIV-infected individual. Mm. And so what they did was that they followed HIV-infected patients, assuming that they were, I believe, they assumed that patients started an infection from age 35, and they followed them out for a lifetime, looking at their medical costs. Mm-hmm. So they found that the medical costs for those patients was $326,500, the lifetime medical costs. So that includes, the antiretroviral therapy, right, and then any other costs that you would get if you were uninfected. Yeah. And, so it's everything. Okay. And then what they did was that they compared it to uninfected individuals, and that came out to be around $96,000. Wow. So what they deduced from this was that if you prevent one HIV infection, mm-hmm, you're saving approximately $225,000. Right. So I know that just seemed like a very, very powerful study, and I think that actually came out. A paper was actually published 2 days ago. I can't remember the journal, but that actually came out recently. Yeah. Very, very nice study.
Right, and it leads some. I don't know if you saw it anywhere. Maybe not, but you would think that data like that and those figures would, like you said, be something that would support the use of pre-exposure prophylaxis more, for investing in pre-exposure prophylaxis prep to prevent HIV infections.
I can't make a comment about that. HIV is kind of, I don't know enough about prep to.
Yeah, I don't know.
I don't know either. Yeah.
So, but it's.
But sure, I think it does really focus on the importance of prevention, and maybe it probably tells you about how much you should be investing in prevention and mm-hmm, what that impact could be. Right. $225 is nothing to sneeze at, and I think the reason why that really stuck with me is that I think this was the first study that really allowed me to, give the cost per SVR some context. Yeah. When you hear $189,000 or $171,000, there's no disease that you could really compare it to. And then until now with HIV, now I can really see that.
That's interesting.
I can see the comparison.
Yeah. And then there's also all of the opportunity costs that get lost when someone is infected with something like HIV, and they can't go to work and they can't go participate in the economy as robustly as they would have been otherwise. So
loss of
that.
In our study, in your study, in the HIV study, no. From potentially, but I don't think they included any quality of life changes, and we didn't include that either. Okay. But it's definitely a factor to keep in mind.
It has an impact on the mass economy as well.
Yeah. Well, we're doing studies right now looking at patient-reported outcomes to kind of assess what the impact that these treatments and SVR could have on quality of life. Mm-hmm. I think that's going to be something very important and something that we're going to be seeing more and more as more treatments come out. Because now is the time that there's a lot of we're coming out with so many treatments that can achieve high rates of SVR, and we didn't have this before. And so where I think this field is changing is it's becoming more of a field where now we really need to know what this impact of SVR is. And because the population of SVR patients is growing, we're finally able to know. We will finally be able to see what this impact will be.
Right. That's very exciting too. Mm-hmm. Well, I think that this was a really great talk, and thank you for coming in and illuminating all of this for us. Yeah,
Thank you.
Very helpful.